This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tesha Monteith with the Neurology podcast. We're back with the November headache series. Well, if you've been following the field closely, you'll know that there's been some exciting advances in the understanding of migraine, but yet so much more that we still need to sort out. Today, I'm here with Professor Messoud Ashina, Scientific Director of the Migraine Research Unit in Copenhagen. I invited him on to help us gain insights into the mechanisms of migraine so we can better understand our patients in clinic. So let's talk about migraine mechanisms. Let's start with the basics. What causes migraine?
Well, this is a tough question, Tisha, and this is one of the most, let's say, frequently asked questions when I see people with migraine in my clinical practice. They usually ask me, what causes migraine? Well, to put it in a, let's say, more or less simple way, I would say this is a very complex disease with a strong genetic component, and it is believed to be a neurovascular disease because it involves abnormalities or alterations in neural and vascular control or tone, we can say it. And there are various factors they contribute to the migraine pathogenesis. I already mentioned genetics, but also environmental and also some hormonal factors. And quite often people with migraine, they think that the cause of the migraine are different triggers, such as stress, certain foods, hormonal changes. But we can also say, based on the knowledge, on the data derived from the basic science, that the migraine as a disease can be affected by the neurotransmitter levels that usually cause so-called aseptic inflammation, vasodilation, or increased excitability of the neurons at the different level, at the peripheral and the central level.
And as you mentioned, migraine as a neurovascular disorder associated with many genes. Over 123 genetic factors have been found. Can we talk a little bit about how, at least what the field is aware of in terms of the genetic factors contributing to migraine susceptibility?
For many years, we talked about genetics in context to migraine, and our hope was that we can find a single gene explaining the migraine. But the things are far more complex. In fact, there are some rare subtypes of migraine when we know that the single genes, or we call them also monogenic type of migraines, they can cause migraine or cause at least the symptoms that we know that are migraine symptoms, such as aura and also migraine headache. And we see that advances in genomics and in general a better understanding of the genetic factors, they contributed also to what we see from the science, to the migraine susceptibility. And we hoped and still hoping that this will pave the way towards the precision medicine, so based on the genetics. But right now, all these calculations are made by quite large sample, the people with migraine, and they cannot be easily translated into the clinical practice. But there is no doubt identifying the specific genetic markers and understanding their role in migraine. In the future, they can maybe help us to tailor treatments to the individual genetics profiles. But this is something I would say in a very premature phase right now. And another aspect of genetics is that also help us to understand the different signaling pathways involved, because if we can correlate these risk variants identified in this genomic status, so we can correlate them to the certain transmitters or the signaling pathways, and it will also enhance our understanding of mechanisms underlying migraine.
And you also spoke a little bit about some hormonal, physiological factors, environmental factors. What do these triggers tell us about the migraine brain?
Migraine triggers is also one of the important topics and also popular topics when we see people with migraine in our clinics, because they mention these trigger factors such as stress, diet, or other factors. One of the problems, Tisha, is that most of these so-called trigger factors we hear from the patients based on the retrospective analysis. So they mention these factors and it is retrospectively, but how reproducible those factors are if we start collecting data prospectively? This is a really good question. So we need more studies to understand about these triggers, because not all triggers are the same for the patients. Some people, they might get migraine after exposure for stress, but other people with migraine, they have a frequent migraine, but not necessarily stress related. So it's very individual, and how reproducible those factors are, this is a good question. The same goes also for the alcohol. It's not reproducible all the time. And that's why when we talk about that, we have to be very careful not to tell the patients avoid everything that it is possible and mentioned before in the literature or by people with migraine, because just avoiding everything can also be a factor reducing the quality of life. If something which is very obvious and it's quite reproducible in individual patients, then we might say, well, you should avoid that. But otherwise, it's quite complex.
I think one of the remarkable things is, as we talk about lifestyle factors and thinking about the migraine brain, is the impact on homeostatic functions.
All our human physiology, it's about the balance. And when we talk about lifestyle factors, it's not only we talk with people with migraine, with people with other diseases, especially with metabolic syndromes, we talk about the lifestyle. And it is also becoming increasingly more and more with age, right? And we also know from the population-based studies conducted in US that one of the major modifiable, I would say, factors for chronification of migraine, transformation from episodic into chronic, is also obesity. So, and the lifestyle changes potentially can improve the migraine. But I still think that it's not the whole thing explaining the migraine. We need to combine talking about these factors with the pharmacological interventions, especially people who really need the treatment because of the frequent migraines and severe migraines. That's what's important, to find the balance about that.
Great. And we're going to talk about the pharmacological interventions, but I want to start with some of the basic stuff. For example, migraine aura. It's long believed that cortical spreading depression is underlying substrate of migraine aura, but is that too simplistic of a consideration?
While this cortical spreading depression, I would say the more correctly will be cortical spreading depolarization, is widely recognized in migraine with aura, but considering it as a sole pathological substrate might be, in my opinion, too simplistic. Because migraine is quite complex. The way we think about the aura, we think about the following sequence. We say, well, first you develop aura, and then you develop migraine headache. But you're a clinician, Tisha, and you know that some patients, they report headache already during the aura phase. Some patients might also report aura after the headache start, after the onset of headache. It's not, as we say, usual presentation with aura and then the headache. There could be some variations in this context. It's important to remember that the migraine is a complex, and that's why one single mechanism cannot explain everything. Another aspect is that we recently showed, for instance, that some of the pharmacological triggers, such as the CGRP or levchromacalin, which is the opener of the KTP potassium channels, they trigger aura symptoms. But what is interesting is that patients first develop a head pain, so it's kind of in a different sequence. We see first activation of trigeminal vascular system, then development of aura symptoms after the triggering within the 1 hour, gradually evolving into the full-blown migraine attack associated with photophobia, phonophobia, and other symptoms. But the sequence which we usually think that first aura, the cortical phenomena, and then the migraine headache, it's not so obvious when we talk about the pharmacological triggers. So maybe there is something else. Maybe the system must be activated first, and then it causes the cortical spreading depression. Because right now, when we talk about the cortical spreading depression, we think about that something triggers the cortical spreading depression. But what is something, we don't know. So that's why there are many questions. And another important question is that some people try to extrapolate data that we gather usually from the preclinical and clinical studies focusing on aura, that we can extrapolate that data into the patient's, our understanding of mechanisms underlying migraine without aura. But to date, we don't have any evidence suggesting of something like a silent cortical spreading depression or depolarization in patients with migraine without aura. So it's also very interesting aspect of migraine pathophysiology, and more studies are needed, to understand these mechanisms also in migraine subtype without aura.
And so we spoke a little bit about migraine aura, but let's step back a little bit more about migraine as a multiphasic disorder with the prodromal periods, possibly aura, headache, and postdrome. What's new when we think about the phases of migraine?
Yeah, this is also a very interesting aspect. When we talk about the phases of migraine, the phases usually also implies the duration. But this is a very difficult question when we talk about the premonitory symptoms or prodromes, because how long they should last, when they should be developed, when we start calling them premonitory symptoms or premonitory phase. One of the most frequent symptoms mentioned in the literature is yawning. But every individual in the world, they yawn, maybe 3-4 times a day. Is it a prodrome? Is it premonitory symptoms? If you put it in context to the migraine, then why not to call it just a start, just a migraine attack or migraine attack? It starts with these symptoms and that's it. There is no such things like a special aura phase. Usually we say that migraine attacks with aura, when you have an aura, it is an attack. And migraine with aura can be also solely aura symptoms and no headache at all, but we still call it the migraine attacks. So why we should call it a phase, why we should call it symptoms not related really to migraine attacks, or we call them as something occurring before the head pain. I think it's too much focus about headache phase, and that's why people try to convince everybody that this is something different and it starts before the headache phase. And this is important because it relates to the central nervous system. Well, I understand this point and I respect this opinion, but we need more data on that. In addition, that recently we did a systematic review on all premonitory symptoms, and we identified more than 90 symptoms. And it's very difficult to say which one is important for individual subject and how predictable the symptoms are when we talk about prospective data gathering. So it's quite complex, let's say, area of research. And we just think that it is important, but we need more data on this topic when we can say, well, it is important in such extent that it can affect our treatment decision making. Particularly, when we talk about the treatment during the prodromal or premonitory phase. So that's why it's an important topic, but I think it requires more. And we cannot say it's a very specific for migraine, because some people also reported these symptoms in cluster headache during the cluster headache attacks. So it's an interesting topic, but more research.
So I'm seeing what camp you're on, and I get it. It's data driven. You're a scientist. And I think that you've raised a couple of points. One is that it's migraine. Migraine is more than a headache. So I think we're all saying the same thing. But as you mentioned, there's potential therapeutic implications to targeting the prodrome, which, while people have been thinking about that for some time with other even long-acting triptans, it's a therapeutic opportunity to potentially help patients.
Yeah, I agree with you, Tisha, but we have to be careful with one thing. If we don't understand much about these symptoms, and how they play a role in migraine pathophysiology and what are the implications if we start treating the patients during the prodromal or premonitory phase, we might have some problems. Let's assume that somebody wants to take a triptans during the prodromal phase. The problem is that we are risking that these patients, that they start taking too many triptans, and we know that the triptans are one of the modifiable factors involved in the transformation from episodic into the chronic migraine with medication overuse and causing the medication overuse. We have known that for many years. So if I start yawning every day, and start taking the triptans every day, I might have a problem. Then you might say, well, maybe it's not the case with the GPANs. Well, it's fine. You can take the GPANs during the so-called premonitory phase. But then you are gradually transforming of taking triptans not as an acute treatment, but as a preventive treatment. And then, of course, it's going to work because we know that the GPANs are very good, in preventing migraine attacks. Then suddenly your acute treatment becomes preventive treatment. You're taking every day almost or every other day because you yawn or you feel tired and you feel that maybe migraine attack is coming. So this is the reason that I'm saying that recognize the importance of these symptoms, understanding of these symptoms, but I think that more studies are needed to see how specific they are and how sensitive the symptoms are in terms of the treatment. Because for migraine attacks, we definitely know that the people develop photophobia, phonophobia, and we know that when the headache starts going away, all these symptoms, we call them also sometimes most bothersome symptoms, they also go away in tandem with headache because we treat the headache. And when we're preventing the attacks, we also reduce the symptoms. We also know about that. So it's an interesting topic, but I think we need more data.
I agree with you about the more data. And I think when we think about treating patients, certainly there would need to be tailored approaches and specific patients that would need that treatment plan should they want to or need to treat during the premonitory phase. But then you also mentioned something about this increased blurring between what we think as acute treatments for migraine and what we think as prophylactic treatments for migraine with the GPANs. And I think some neuromodulation being good examples of that.
Correct.
So I think we did speak about some controversial areas in migraine. Any other topics that you just want to 1, 2, 3, what you think are some big areas of controversy?
I think that the triggers, again, because when we talk about the triggers, how reproducible those triggers are, this is, in my opinion, also one of the controversial topics in migraine. Another controversial topic is about estrogen. The estrogen has been around in migraine pathogenesis for many years. The estrogen withdrawal, fluctuations are the potent triggers for migraines. And but the problem is that the data that we are operating with, we recently also reviewed this data about the estrogen hypothesis. It's poor based on the study of many years conducted in 6 patients and only 3 patients that was showing that the drop in estrogen was causing the migraine attack. But it's absolutely not sufficient to claim that. So again, not denying that these factors are extremely important in migraine pathogenesis, but also with some clinical implications. But we need also more research in this field. It just illustrates that we have to be careful when we're going and keep referring for something being conducted 40 years ago, 50 years ago, and taking as obvious, as like an axioma, and we believe in that, and that's it. We need to question that. And with the modern technology, with modern approaches to things, we can redo these studies and we can understand better very important aspect of the estrogen and migraine. The hormonal aspect of migraine is extremely important. And also why some women after menopause, they still have migraines, why some stop having a migraines, why in older adults, you see sometimes still frequent migraines, and in some it just vanished, it goes away. There are many interesting, controversial topics that we need to understand.
So you spoke about the estrogen withdrawal hypothesis, and I think that's a valid point that we need more research. What emerging research is there with the role of estrogen and neuropeptides such as calcitonin gene-related peptide and potential interactions that might explain migraine?
Yeah, this is also a very popular topic right now to explain efficacy of medications, the new biologics, but also the anti-CGRP receptor small molecules, the GPANs, in terms of the treatment response, female versus male. But the problem is that, again, none of the studies they powered to study this aspect on the differences in response based on the gender. But what we see that in the monoclonal antibodies, at least trials, there was no such a difference between these two group patients. Another aspect was also about how the women and men, they could be different in terms of the hypersensitivity to the CGRP. In fact, we just published a few days ago a paper on the CGRP provocation experiments, how the hypersensitivity, that was exploratory analysis, how the clinical and sociodemographic factors they can influence the CGRP-induced migraine attacks. There were a number of different factors, including the gender factor, but there was no difference in terms of hypersensitivity between men and women in this study. So showing that they were equally hypersensitive when we infuse the CGRP and provoke migraine attacks. So this area is still important, I would say, needs more research and more answers are needed. But I think that, again, we need a good powered study.
And I think we always talk about response rates and things like that, but what do non-responders tell us about migraine biology and in specific CGRP inhibition?
Yeah, but this is also a very important topic, non-responders to CGRP inhibitors. When you look at this long-term data, I'm talking about the status after the randomized clinical trials, the double-blind phase. Most of the studies included so-called open-label phase. And during this open label phase, they assessed long-term efficacy, safety, and tolerability of these different medications. I'm talking about the new medications. And usually when you see the nice curve showing you a nice long-term efficacy and safety and tolerability a year after, 2 years after the treatment initiation. But one major problem is the following. If you look at the number of patients after the double-blind phase enter the open-label phase, and you look at the numbers of patients still there in a year or 2 years after, you see a significant drop. And of course, you would see a nice response because all of the data that you have at the end of the collection period, those who are responding. But what about the discontinuation? What about those people who discontinued for the different reasons? Could be tolerability, could be lack of efficacy, different reasons. So that's why I think that we need to talk now about the retention rate. How many people stay still in the treatment in a year and 2 or 3 years after the initiation of the treatment? Do the patient develop tachyphylaxis, and it stopped working? So those are very important questions, including the questions why some people not responding. We try to address this issue in our experiments because we know that many people are now fearlessly searching for the biomarker to explain why some people are responding, why some people not responding, why some poor responders, super responders, etc., etc. It is notoriously difficult to find a single biomarker, I would say immediately, but we keep trying. One of the things we try to do is the following. Because based on the clinical trials, we see that about 60% of people, they're responders, and about 30 to 40% of people, not responders. When we give the infusion of CGRP to people with migraine, about 60% of participants develop migraine attacks after the start of infusion of CGRP. And about 40%, they do not report. Well, we asked the question, can this hypersensitivity explain the treatment response? And the obvious was that to start these provocation experiments before the people enter the treatment and start treatment with one of the monoclonal antibodies. And we did it with erenumab just to see that those who are hypersensitive to CGRP, they will respond to erenumab. And those who are not hypersensitive to CGRP, they will not respond to erenumab. But what we found was quite surprising. Even those who are not responded to the CGRP infusion, in other words, they did not report migraine attacks after the infusion of CGRP, at least 60% of them had an effect of erenumab. So we failed to show that this infusion can be used as a test to predict responders or non-responders. Just to illustrate you how difficult this topic is, but I'm sure that many other colleagues around the world, they're trying very hard to understand that. The problem is also, Tesha, that you need to find something which can be easily applied in the clinical practice. These fancy experiments with imaging, they are imaging studies based on the number of patients, the group comparisons. You understand what I mean? So it's very difficult, almost impossible to apply these methods in the clinical practice. We cannot do the imaging and then they start the treatment and decide based on the imaging whether we're going to treat or not treat this patient. So that's why we need a really robust and validated markers so we can predict and then we don't have to go through the treatment. So right now we operate with the following, let's say, concept that it is 3 months treatment. If people respond, they respond. If not respond, either we switch, if it's possible in some countries. In my country, unfortunately, it's not possible to switch due to lack of efficacy, or we stop the giving the treatment. So this is the way we operate. So we don't have a predictors yet.
So let's talk about some of the triggering experiments that you mentioned. Give us some of the major takeaways. You mentioned one, the lack of reproducibility at times, and the lack of us being able to understand response rates to predict medication response. Is there anything else? And I know there are a number of different pharmacological agents.
The experiments that we conduct here in Denmark, in my opinion, are important because what we do, we're trying to identify different signaling pathways in vivo in humans, which is quite unique that you cannot do it in other diseases, right? I mean, we cannot provoke MS, we cannot provoke Parkinson in people suffering from these diseases because it would be impossible to do that. We're talking about that's progressive and chronic diseases. In case with migraine, when we know that the various factors are triggers for migraine, such as alcohol or other factors that we talked about before, you can actually trigger the disease because it is self-limiting, it goes away, and you can treat that. And upon, of course, consent from the patient, you can try to understand migraine pathophysiology by giving the various triggers, the natural occurring molecules that are possibly involved in migraine pathogenesis. And if this particular signaling pathways provokes attacks, then you have this specific signaling pathway involved in pathogenesis, and maybe you can develop something that can inhibit this pathway by, let's say, by inhibiting either the ligand, the molecule itself in human body, like we have anti-ligand monoclonal antibodies against CGRP and possibly in the future for PACAP, but also their receptors. So this kind of experiments opens the new avenue of new possibilities for the drug development. That was the case with the CGRP. These experiments contributed in the CGRP discovery in migraine. We talked about PACAP as a possible target. What I'd like to mention about the proof of concept trial, which was called HOPE trial. And this trial was designed to assess the efficacy and safety tolerability of a single intravenous infusion of the monoclonal antibody against PACAP for migraine prevention. And this study was conducted in adults with migraine who had 2 to 4 unsuccessful prior preventive treatments. And in this study, the primary efficacy endpoint was the mean change from baseline in the number of monthly migraine days over weeks 1 to 4. Okay. And 2 doses of the drug was administered intravenously over 30 minutes. And this study was a placebo-controlled study. So this trial met the primary endpoint of a greater reduction of monthly migraine days over the weeks 1 to 4 with anti-PACAP monoclonal antibody high dose versus placebo. So this trial was a positive trial and demonstrated in the proof of concept trial that anti-PACAP monoclonal antibody was efficacious in migraine prevention. And importantly, it was well tolerated and no safety concerns were observed. But in order to firmly establish the efficacy of this drug in migraine treatment, we will need the next phase 3 studies. And this is something that I'm sure it's in the planning stage, and we will hear more about that in the next years come. And one of the things that we're also doing here is that focusing on so-called intracellular mechanisms. Because most of the molecules that we inhibit now on receptors, they're on the surface of the cell. They are the upstream mechanisms, but they are also downstream mechanisms. By provoking migraine using the downstream molecules, we can achieve a higher migraine induction, suggesting that in fact, that those mechanisms are important. And one of the recent studies that we published recently in Brain showed that even if we block the CGRP receptor, but with a very powerful medication, the monoclonal antibody against CGRP receptor, by giving the drug which acts intracellularly, we were able to induce migraine attacks the same magnitude if you give a placebo. So, meaning that the CGRP blocking effect was not efficacious in this case. And that's why maybe some migraine patients still report migraine attacks, because it's not just a single molecule, it's much more complex. And by targeting these intracellular mechanisms based on the data derived from the human experimental studies, maybe we can have more efficacious drugs. We don't know, acute or preventive. This is something that the future will show.
So you've already kind of alluded to a number of new targets that we should be on the watch for, but go ahead and list them out for us.
I'd like to mention the PACAP. The PACAP is one of the natural occurring molecules in human body. In human body, it exists in two isoforms, PACAP 38 and PACAP 27. So it's just the difference in terms of amino acids. But PACAP 38 is more widely distributed compared to the PACAP 27. And back in 2009, where for the first time showed that intravenous infusion of PACAP induced migraine attacks in about 60% of the patients. Very similar to what you see with the CGRP infusion. At that time, we suggested that the PACAP or PACAP's receptors could be a target. Well, what is interesting about the PACAP is also in the big family of peptides with another peptide, important vasointestinal peptide called VIP. And both are acting on the same receptors. And these receptors are located in the different compartments, including the vascular smooth muscle cells, but also in neuronal cells. And while they share these receptors, we studied the difference between the PACAP 38 and VIP, and we found a difference. In spite of being both very strong vasodilators, we saw the different responses in terms of migraine induction. More than 70% of the participants developed migraine attacks after the PACAP 38 and only 18-20% after the VIP. So this difference we explain maybe by preferential effect of PACAP on the so-called PAC1 receptor. And we suggested that the PAC1 receptor could be a new target. The monoclonal antibody was developed against this PAC1 receptor, but the study, unfortunately, was negative. So they didn't show any difference between two doses of this monoclonal antibody compared to the placebo. Well, some people say then this receptor is not involved. Some people say maybe it's more complex. Maybe you need a splice variant of this receptor in order to achieve this anti-migraine effect. What is interesting about this PAC1 receptor, it's located in neurons, but not really found in the vessels. I don't know if it's a difference. We only think that I can say that when you give the PACAP infusion, you get a long-lasting dilation in spite of the short half-life of PACAP. Immediately after you stop the infusion, within the 10 minutes, it should be gone. But apparently, this effect of the dilation lasts for 4 hours, at least 4 hours. For the VIP, it was very short, and maybe that's why so few patients developed the attacks. But a couple of years ago, we published a paper when we give a 2 hours infusion of VIP, and then we achieve the same induction rate as after the PACAP, after the 2 hours of fusion of VIP. So those receptors, VIP itself, PACAP itself, they are not our drug targets. And the recent study, the proof of concept study, which was presented during the International Headache Congress in Seoul in September, reported that the 2 doses of anti-PACAP, monoclonal antibody against PACAP, was efficacious, safe, and well tolerated. And that was a double-blind study. But as I mentioned before, we need more studies, particular phase 3 studies, to firmly establish the role of PACAP and also with the treatment implications. One last thing I'd like to mention about the PACAP, and it's an interesting question I usually receive from my colleagues. It's about, could it be that migraine patients are different in terms of signaling pathways? In some patients, CGRP is involved. In some patients, the PACAP involved. Could it be that those who are not responding to the CGRP monoclonal antibodies, because CGRP is not involved in their migraines, but PACAP is involved, and maybe the anti-PACAP agents could be efficacious in these patients? Well, it's a good question. We don't know about that. Whether the PACAP-induced migraine, it is dependent on the CGRP, We don't know, but I can tell you that we conducted a study when we tried to inhibit PACAP-induced migraine using the anti-CGRP monoclonal antibody, but I don't have results right now. But the major question is that whether the PACAP signaling pathway is still dependent on CGRP or not. If it's not, we have an interesting perspective. First of all, I think that anti-PACAP agents, if they're efficacious, they can be used at the same level like we use anti-CGRP agents, because we need to study that in all patients, and apparently if most of the patients are responding, so the PACAP signaling pathway is involved. Then there is a prospect also to study in patients who are not responding to the CGRP. Okay, it's fine. We can also study in this patient. And the third option is that in the future, maybe the combination, maybe a combo effect, the anti-CGRP and anti-PACAP. This is something very interesting, and we have to study in the future.
Excellent. I think this is such a fascinating conversation. It's so nice to see different targets and different ways of thinking about the migraine mechanism. I want to ask you one last question about some of the more recent breakthroughs in our understanding of migraine. What excites you the most?
Well, there are many interesting things are going on in research, but what I think that what excites me now more is we're going back to imaging. I think that imaging to understanding the fundamental mechanisms are very, very important. And I do see that the people are planning and doing some experiments, very nice experiments, using the imaging to understand the basic neurobiology of migraine. The symptoms that we mentioned before about the premonitory symptoms or prodromes in context to understand what are the sites of these symptoms, and how they relate to the migraine pain, etc. So all this circuit of the different events during the migraine attacks are very, very important. One of the major challenges what I see in imaging is reproducibility, but I think that we're going to figure out this issue together with other colleagues. We need some consensus about that, how to study. And that's why I try to call my colleagues also, to discuss this topic because it's important. And I see a lot of potential of imaging. Another aspect that I see the potential is that, of course, in the drug development, there are many things are going on still. The whole area of migraine and migraine treatment, it's quite exciting, and more things are coming, I can promise you. Another things that I mentioned from our research, from our lab, it's about the signaling pathways involved in migraine, in particular the downstream mechanisms, intracellular mechanisms. We have more studies coming up. The studies focusing on this aspect and trying to understand whether, again, these mechanisms are dependent on CGRP or the PACAP on other molecules, the upstream molecules. It's also a very interesting topic about the migraine hormones. It's a very, very popular right now. I'm sure that the more studies will come. But again, we need rigorous studies. We need, from a methodological point of view, very good studies to understand this important topic. Genetics will be still around, but I think that will take more years before we can start using genetics in the clinical practice, because it is still quite complex, when we're talking about identifying the genetic factors which contribute to migraine's susceptibility, but also to the treatment responses. The studies that I mentioned before about the CST, cortical spreading depression, in relation to migraine, still very, very important. And I would like also to mention importance of the preclinical studies, the basic science. These experiments are extremely important. Regardless how much we can do translational research in humans, such as I mentioned before with human provocation models, we need preclinical models. We need models in animals to understand things that we cannot really study in vivo in humans. So those studies are very important. And so I think that the most important discoveries I would mention last couple of years is the role of PACAP, I would say, because this is something potentially can bring a new treatment, in a very short period of time. So this is why I think it's important.
Well, typical of you, you're excited about everything. Thank you so much for being on our podcast and helping us shed the light on a really difficult condition.
Thank you, Tesha.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.